Okay. Again, my name is Tammy Frank. I'm with the Nebraska Medical Association. I'd like to welcome you all to the second in a series of Foster Healthy Weight and Youth webinars. Today's webinar will focus on non-alcoholic fatty liver disease in children. We'd first like to thank Dr. Carla Lester with Teach a Kid to Fish and the NMA's Childhood Obesity Prevention Project, Holly Dingman with the Department of Health and Human Services, Nutrition and Activity for Health Program, Dr. Christina Fernandez with Creighton University Children's Physicians, Dr. Sally O'Neill and Jeff Klein at Creighton University CME, and Dr. Ruben Kuras with UNMC's Children's Hospital and Medical Center for all the work they've done to make this webinar possible. I'd like to introduce Holly Dingman, who will talk about the CME credits associated with this webinar, and will give the background of the Foster Healthy Weight and Youth model. Holly is a registered dietitian and the nutrition coordinator for the Nutrition and Activity for Health program with Nebraska Department of Health and Human Services. Holly?
Thanks, Tammy, and good afternoon, everyone. The Creighton University School of Medicine designates this live and enduring material activity for a maximum of 1 AMA PRA Category 1 credit. The information in this training has been approved 1 continuing education contact hour by the American Medical Association, Category 1 credit, Nurses Association, and Commission on Dietetic Registration. A detailed information sheet containing this information accompanied this webinar registration and can be found on the Creighton website. The Creighton University School of Medicine is accredited by the Accreditation Council for Continuing Medical Education to provide medical education for physicians. After the webinar, you will be sent a link to the post-test and evaluation via email. You may also visit cme.creighton.edu for more information. This activity has been planned and implemented in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education through the joint sponsorship of Creighton University School of Medicine, Nebraska Medical Association, Teach a Kid to Fish, and Nebraska Department of Health and Human Services. Neither the Planning Committee or speakers for the webinar series have any conflicts of interest or disclosures and have signed statements claiming as such. Foster Healthy Weight and Youth is Nebraska's clinical childhood obesity model. The clinical resources have been and are continuing to be disseminated to physicians across the state. It's a comprehensive model with a toolkit, pocket reference, free CME training video, which outlines the steps in assessment, prevention, and treatment in the primary care setting. There are also consistent messaging, patient brochures, and posters to resource your office. All of these resources are free and available through the NMA's Child Obesity Prevention Project website. The objectives for the Foster Healthy Weight and Youth webinar series are to explain and illustrate childhood obesity comorbidities, describe and illustrate assessment of comorbidities in the primary care setting, and describe and illustrate treatment of comorbidities in the primary care setting.
Okay, thanks, Holly. Today's webinar is titled Non-Alcoholic Fatty Liver Disease in Children. Our speaker is Dr. Ruben Kuras. Dr. Kuras joined the transplant team at the University of Nebraska Medical Center's Children's Hospital and Medical Center in Omaha as Medical Director of Pediatric Liver and Intestinal Transplantation and Chief of Pediatric Gastroenterology, Hepatology, and Nutrition in 2009. He received his medical degree from the Universidad Nacional de Panama School of Medicine, Panama City, Panama, and completed fellowships at the UCLA School of Medicine in both clinical and advanced clinical gastroenterology and transplant hepatology. Prior to joining the University of Nebraska Medical Center, he served as Medical Director of Pediatric Liver and Intestinal Transplantation, Director of Pediatric Hepatology, and Co-Director of Intestinal Rehabilitation and Transplant Center at Children's Memorial Hermann Hospital, University of Texas, Houston, Texas. Dr. Kuras specializes in the care of patients with liver disease, obesity-related liver disease, short bowel syndrome, total parenteral nutrition, and those in need of liver and intestinal transplantation. He is board certified in pediatrics, pediatric gastroenterology, and transplant hepatology. With that, Dr. Kuras, I'll hand this over. Let me get you to your slides here, and I'll hand this over to you.
Thank you very much, Tammy. Today, we are going to talk about fatty liver disease in children, non-alcoholic fatty liver disease in children. This is a problem that we have been noticing, or it has been increasing our awareness of it over the past, I will say, for sure 5 years, and start some concerns over the past 10 years. But as in any kid with overweight or obesity, we always wonder, well, if there's fat in the liver, what kind of issue that could create? Is this truly a problem or not? And that's something that throughout this presentation, I will make that point, that this is a very concerning issue for kids with obesity. I will run a couple of slides, but basically we have seen the obesity problem increasing over the past 20 years in a very alarming way. The spectrum of the problem basically has been changing truly over the past 10 years or so. But now we see, in the CDC behavioral risk factor surveillance system, they did this. They do each year. They do calls to different houses and stuff in the U.S. Adults, and basically try to figure out the incidence of obesity or overweight in adults. And we can see what's more or less about in 2000. In 2000, we can see that this alarming picture here that we see in this slide, where the red states basically represent the states that have more than 20% of adults being overweight, and we can see how the state of Omaha is involved in that is included in those states, and Colorado basically having the less at that time. And then more recent one in 2004, we can see still we are in the 24%, but there are some states that are over 25%. They are south from us, but this is a problem that is really changing in the United States, and unfortunately is bringing a series of comorbidities and issues, new issues, to us that work in the medical field. And we can see also how that has been changing in the pediatric population. Here we have in this slide the age-adjusted prevalence of overweight through some of the cycles of NANS 1 to 3. But here we have that more than 95th percentile of BMI were represented here, and we can see the percentage. We can see here the first cycle, which was 71 to 74, is represented in purple color, and we see the bright green color basically being the 88 and 94. And this has keep on changing, but we can see here in all ages, the school-age kids, 6 to 11, boys 12 to 17, girls 6 to 11, girls 12 to 17, how the incidence of obesity has been increasing through time, and nowadays in some states it's approaching basically almost 35%. 1 out of 3 kids may be overweight, and obviously having the comorbidity that is involved. Then the body mass index is what we use, and this is something that the awareness of the use of the body mass index has been really stressed over the past 10 years, and out of that, truly over the past 5 years, where we have been truly stressing why BMI, body mass index, should be part of the growth charts, or that we use in every single visit of our children in the primary care physician offices. BMI helps us when you adjust it for age. We can understand the health risks that they have. There have been nice studies looking at the correlation of risk factors for cardiovascular disease, hyperlipidemia, hyperinsulinemia, hypertension, and even now for liver disease. Very nice studies correlating the BMI to the risk of these problems. And also BMI is adjusted And then we can see how there's issues in relation to hyperlipidemia that relates also to BMI early on, even in the prepubertal patients. BMI also compares well with weight for stature measurement and measure of body fat. Obviously, there are some potential issues when someone has increases of muscular mass, but I think as a screening tool is really good. Then we can see in this slide, it's a study published in the New England Journal of Medicine several years ago. But basically, in this study, they look at the likelihood of someone having a BMI. Here we can see, just take here, where the BMI less than 85th percentile. When we look here at the BMI at less than 85 and more than 85th percentile, and more than 95th percentile here in the pink. But we can see here how that translates into the likelihood of someone being obese at 25 years of life. Then, for instance, if we have a patient that is about 5-year-old, that the BMI is over the 95th percentile, the likelihood of being obese by age 25 is about 52%. And we can see if we have a kid that is a 9-year-old and his BMI is, or her BMI is over the 95th percentile, we can see how the likelihood of being overweight by 25 is going to be about 69%. We can see how that goes up as the kids keep on growing. Then identifying those kids early on is going to be extremely important because of the impact that we can have in the prevention of comorbidities such as liver disease, hypertension, and hyperlipidemia, diabetes, and so forth. Here, just to remind how the BMI curve looks like, this is for boys. And I think what I want to point out in this slide is that we cannot go by the absolute number. And an example of that is we usually start using that. This really correlates better after 2 years. Before 2 years, we really use the weight for height. But here, for instance, if a 2-year-old has a BMI of 19.3, that is going to be at the 95th percentile. Why I'm saying that is because for adults, we use different numbers. We use, you see here, for a 20-year-old, the BMI to be close to 95% is going to be at 30 or above. Then we cannot use the absolute number. The same happens, we can see that the BMI tends to decrease during the first, after 2 years old, during the next 2 years, and then start going back up, and then it change up as, kids start hitting puberty. Now, how much we use BMI, and hopefully it has been changing, but this is a very interesting study published by Dr. Barlow in pediatrics and her group. And basically, here, this is a survey that was performed among pediatricians, nurse practitioners, and dietitians, and they look at how frequent, how will these healthcare providers will assess obesity. And it's interesting because most of them, by that time, they were using clinical impression as the main one. And clinical impression, unfortunately, can be deceiving. And little or barely 12% for pediatrician and 20% for dietitian were using the BMI percentile. Some of them were using the absolute number of BMI, and that was stressing that BMI numbers change through age. Then it is important to look at the BMI. This is a very interesting study because at that time, this is just about almost 9 years ago, but at that time there was not a lot of use of BMI, and that has changed through time. Also, awareness of comorbidities has changed. You look at the same study, and we can see that most of us knew, when you look at pediatricians and middle levels, most of us knew about hypertension being a problem in kids with obesity. Endocrine problems also, but they still will go down to 60%. But diabetes type 2, how many of them were looking into that kind of comorbidity, were about 38, almost 39, and 41, almost 42% of the nurse practitioners. But interestingly, GI disorders were not really asked for, 22% at that time. And that has been changed throughout education of the medical personnel. Here we can see the usual profile. Like if you have this survey, the same survey by Dr. Barlow, we see that lipid profile will be performed by pediatricians almost in 60% of the patients, and by mid-level about 50% of the patients. And here, how many will look into cholesterol? We can see 65%. Insulin levels just 17.5%, 4.9%. Glucose tolerance or glucose 29%. And interesting here at that time, liver enzymes, it was just look at 10% of the pediatrician will ask for liver enzymes in the overweight patients. And that's an awareness that has been improving over time, but just point out that how this field has changed or needs to change in the future. The same, it was about asking for family background, and again, gout bladder disease was the only thing was asked for, in no liver disease or cirrhosis and so forth. Cardiovascular disease, we all know that if you see an overweight kid, usually it's part of our family history, as well as hypertension or dyslipidemia. Then, why we should worry about liver disease in particular? It has been not until recently that the awareness about liver disease has increased. But liver disease, unfortunately, is fairly common in the obese children. If we look at some studies performed around 2000 by Strauss and Rashid and some of these groups, basically the incidence of having elevated transaminases in obese children is about 15 to 25%. Then the interesting thing is, this is very interesting here, is that about 75% of these children will have fibrosis or even cirrhosis. This incidence of fibrosis is higher than the adult population. Then for some reason in the children that gains weight and they get fat deposit to the liver, and we'll look at this in a little while in some of the next slides, then they will start developing fibrosis in a higher incidence than adults. And the adults drink alcohol and do some other things to their liver, something that kids do not do. Then something happens in the young liver when it's exposed to this kind of injury. And that is important to know because, and important to address because, this is going to be a problem, healthcare problem, because these children will develop cirrhosis early on and will be candidate, or they will need transplantation early on. And that will be another cause of morbidity and potential mortality in this population. Then Strauss looked at this in a Nance cycle tree, where we can see where this is coming from. We can see normal weight kids, the incidence of ALT, which is one liver enzyme, being high was 1.5% versus as your BMI go over 85th percentile, but less than 95th percentile will be around 5%, and almost 10% if the BMI goes over 95th percentile. The other interesting thing about this study is that when you look at the incidence of increase of hemoglobin A1C, is here in this study by Strauss, you can see that the hemoglobin A1C tends to be a little bit higher in the kids that have elevated liver enzymes. And that was important for the pathophysiological process that we'll talk about in the next few slides. And then also the triglyceride level will be higher, more than 200%, to 200 milligrams per deciliter, in 23% of the patient, which was statistically significant. Another interesting thing, and I think it's important for pathophysiology, is the fact that the serum antioxidant here, vitamin C, vitamin A, and vitamin E, they were slightly decreased or lower levels in the patients who had elevations of the liver enzymes. That potentially could mean that they have a low antioxidant status. Here, this is a paper that we published back in 2007 when I was in Houston, but we look in 570 kids and with about 391 of them having normal ALT. These were kids overweight Hispanic children. There were 517. And then we can see here that normal ALT was in 210 and 181. And we compared there against the ones that had the elevated liver enzymes. There were about 126 in total, and 68 boys and 58 girls. Out of this visit table, the things I want to point out are the fact that the insulin level was higher in these kids with elevated liver enzymes, where we compare them against the ones with normal ALT. Then also we see here that the triglyceride level was also higher here. We can see here the kids that have elevated liver enzymes or ALT versus the one that did not. And the next thing will be the TSH here, that we can see that also tends to be a little bit higher in the kids with elevated liver enzymes. Then what is the role that this plays in the pathophysiology of the process is something that we have been trying to sort out. In the same study that we performed, published in 2007, we find out also that some of the markers of systemic inflammation were also putting out toward there was a systemic inflammation in these kids. We can see here that the adiponectin level was a little bit lower in the kids that have elevated liver enzymes. Then the leptin level was higher than statistically significant, and there was a systemic inflammation. CRP was elevated in the kids with elevated liver enzymes, and that was again statistically significant. Then there's the conclusions we drew out of this paper. There was the risk for developing non-alcoholic fatty liver disease was high in the overweight Hispanic children. The proportion of at-risk children was not influenced by gender, age, or maturation status in the children. And we found that the guys that have elevated ALT was predicted by the severity of the obesity, something I didn't present in the slides, central adiposity, which we all talk about the importance of central adiposity, hyperinsulinemia, hypertriglyceridemia, elevation of the TSH, and the markers, having markers for systemic inflammation. There's a systemic inflammation process going on that may predispose them to have liver disease. Then, what is the issue with having fat in the liver, having inflammation in the liver? What is the big deal? Well, the issue, unfortunately, is that the liver disease can progress into cirrhosis, and that's why we see in this paper, one of the early on papers, pointing out that this could be a progressive process. Here in this paper, they look at 23% of adults with cryptogenic cirrhosis will have both obesity and diabetes. What they did is they got a group of adults that were diagnosed with cryptogenic cirrhosis, meaning that they didn't know why they developed cirrhosis. And when they look at that retrospectively, they find out that 1 out of 4 patients will have obesity and diabetes. That if you separate them out, that was the combination, but 55% will be obese and 47% will have diabetes. Then they start establishing the link between insulin resistance and liver disease and a progressive liver disease. And we know that in cases about to be more a group of progressives, as we point out before, is that there is about a 75% incidence of fibrosis, cirrhosis in kids with obesity and elevated liver enzymes. The thing is that this keep on progressing, this keep on having the studies that keep on showing us that fibrosis, cirrhosis can happen in these patients that have elevated liver enzymes, non-alcoholic fatty liver disease. The progression is, and we can see in this study that they show us about the same, that the incidence of cirrhosis was a little bit higher in those patients with NASH, alcoholic steatohepatitis, will have, if they have a fibrosis, they will have the tendency to progress into cirrhosis in this long-term follow-up paper. Now, the next thing is that, unfortunately, also once cirrhosis happens, then there's the risk not only of end-stage liver disease, obviously, and decompensation and need for transplant, but the other issue is the potential progression to develop hepatocarcinoma. And they find in this study here, by Draziu, is that 27 obese patients with cryptogenic cirrhosis, 29.6% had hepatocarcinoma, not statistically different from, and this is compared to patients that had cirrhosis that were not obese in relation to hepatitis C. Then it's fairly, is about the same incidence of HCC or hepatocarcinoma. Then with this series of papers, basically what it's showing is that non-alcoholic steatohepatitis can progress to cirrhosis, and not only that, but also patients with cirrhosis secondary to NASH will have a high risk for developing hepatocarcinoma. Therefore, this is a problem that we need to address to prevent all this to happen. Actually, there are some experts that are telling us that the main cause of transplantation, or the principal diagnosis of patients that have received a transplant nowadays is hepatitis C, and that obesity-related liver disease, or NASH, is going to be the #1 cause in the next 5 years or so. It will surpass hepatitis C. Then in kids also we have the issue that this is more progressive, as I mentioned before. This is some unpublished data that is under review, that a paper or a study we work that we have 40 patients. Out of those 40 patients, we have 35 children that demonstrate some degree of fibrosis in this study, with 40 patients that has elevated obesity patients, obese patients that have elevated liver enzymes. Then the incidence of fibrosis is very high. But not only that, in our study, 26 out of 40 will have at least stage 2 fibrosis, which is a more advanced fibrosis when we classify it as we look at the histology. But therefore, it's not only that having some fibrosis, most of them will have advanced, in a way, fibrosis that could progress easily into cirrhosis. And in this study, we have 2 patients out of 40, or around 5%, will have early cirrhosis. Then how this happens? Basically, there's this two-hits theory in steatohepatitis, where first what happened is there's accumulation of macrovesicular fat in the liver. Triglycerides get accumulated in the liver as the person starts gaining weight, as the child starts gaining weight. And here in this slide we have a nice paper from Angulo in New England Journal of Medicine, where he points out some of these mechanisms. But basically, insulin resistance develops in these patients as they start having more fatty acids, secretion of leptin, as we mentioned in our paper, TNF-alpha, that interfere with the normal interaction between insulin and the receptor. That's going to lead to insulin resistance, what is going to perpetuate accumulation of triglycerides. Here we can see it in the hepatocyte, because now there's a decrease in apolipoprotein B100, and then there will be less VLDL coming out of the cells. Then it's going to start accumulating fat or triglycerides in the hepatocyte. Then after that, what happened is that this accumulation of triglycerides in the hepatocytes is going to lead to some injury to the mitochondria. There's going to be generated reactive oxygen species, hydroxyl radicals, and superoxide anions basically are going to be free in the hepatocyte. Now this is going to cause injury to the cells, and then the lipid peroxidation products also will cause direct damage to the cell, affecting the membrane function, and this is going to stimulate the fibrosis or the connective tissues to cause fibrosis in the liver. Then there's an increase on oxidative stress that is going to be worsened by having not a good antioxidant status, as we saw before, and there can be some environmental issues, infections, and so forth. That is going to start leading to the patient. That will be the second hit then. Then we have the second hit, which is the oxidative stress that comes after the first hit, which was the accumulation of fat in the hepatocyte. Then how do we treat this problem? And I have to put this slide because mainly the only thing that we know right now that is really safe to deal with this problem is just weight control programs, promoting healthy eating, promoting physical activity. Those are the things that are safe at this point. We don't have a medication that is safe that will help to decrease weight. There's a lot of products out there that claim that they will make you lose weight really easy. That's not the case, unfortunately. Then what is important is to change the way of living, the way we live, basically change the habit, which is extremely difficult as you get older. That's why it's so important early intervention, how we can change habits and the healthy eating, how we can stimulate the healthy eating, how we can stimulate the physical activity in a society that is moving more toward technology that promotes for us to stay sitting down in the couch, as we can see here in the Healthy Living for Life. I took this slide from that program, where we can see this is a typical, unfortunate picture in some of these houses, in our houses, where, still, we have the TV very close to the child, but still he needs the remote control. He sits down here for 2 or 3 hours, going to have refined sugar here through this pop and a lot of empty calories through this fries, and also has another pack here. This is unfortunately a picture is becoming more and more common in our society. TV is becoming a babysitter, computers, video games, and so forth. Those are the things that we need to work on, how we change the habit in a society that have all this technology. That's going to be one of the big challenges. And the other thing is about fast food, where we are a busy society where cooking is not easy anymore because everybody's working and running back and forth to different activities. Those are the things that we need really to work on, because this is the picture we want to avoid. This is from Felicia Webb, Generation XL. She won an award through UNICEF with this picture. I helped, was part of this project. But we have this kid. This kid is a teenager. It's a 13, 14-year-old kid that now needs a BiPAP, needs a CPAP, but needs a BiPAP, sorry. It's a machine to help him to breathe and stay alive, basically, because this kid now suffers from sleep apnea. And this is unfortunately what we are dealing with at this point. This may be extreme, or unfortunately, this is something that is happening in our society nowadays. And we really have to work on it, because we are probably in front of a generation, this Generation XL that Felicia Webb calls, is a generation that may die before their parents, which is very, very dramatic. But this is probably the case, because these kids are developing diseases that we used to see in adults. Then how we treat this the liver disease part is, we try to address the oxidative stress status. We can see here in this slide, I just want to bring this study because they have, this is an adult study, but basically show how the oxidative stress and antioxidant status in NASH is affected. And we have here 18 adults with the biopsy-proven non-alcoholic steatohepatitis. And this study compared this against 16 controlled, who were non-obese. And then the oxidative stress status is look at MD8 and nitric oxide, and antioxidant status is look at true glutathione levels, GSH peroxidase, and GSH reductase, and superoxide dismutase, and all these different substances. They analyze them in the bloodstream. And basically, they find out that, in people with NASH, the MDA was elevated, which is an oxidative stress radical measurement. Nitric oxide was also statistically significant here. There was a trend here, statistically significant again. And also looking at the GSH and GSH peroxidase and all this different component basically, but they basically conclude that there was an impaired antioxidant defense mechanism that could be important as a factor in the pathogenesis of NASH. And then what they suggest at that time is that treatment approach to try to address NASH should look at antioxidant status and how to improve the antioxidant status in these patients with non-alcoholic fatty liver disease, or in this case, non-alcoholic steatohepatitis. Then the approach that we are looking at, other than, of course, weight management and increase in physical activity, which are the main ones, and I think these are the ones that we really have to stress before going into any medical treatment, or medication treatment, I should say, or drug treatment. But one of the things that we need to address is the insulin resistance. That's why some of the approaches to liver disease has been through using medications that will improve the interaction between the insulin and the receptor. And also, since the oxidative stress could be a potential factor, increase in oxidative stress, then we are looking to antioxidant therapy to try to address the problem of non-alcoholic steatohepatitis. And as we remember in the NANOS cycle 3 paper from Strauss, we saw that they have decreased, the patients with elevated liver enzymes and obesity have low levels of vitamin E, vitamin A, and vitamin C that are antioxidants. Here in this slide, we try to summarize in the next 2 slides some of the attempts that has been done in using this medication. We have in pediatrics, this paper here is highlighted in yellow, paper in pediatrics where a pediatric patient, 11 patients that were treated with vitamin E, and it was looked at, the liver enzymes were looked at after 4 to 10 months, and there was improvement in the liver enzymes and after normalization in almost all of them with no histological changes. But unfortunately, that has not been duplicated that clearly, but also the oxalic acid has been used, as well as N-acetylcysteine and gemfibrozil and some other, with the keep in mind the antioxidant approach to it. But also there has been some studies looking, and also more recently, that basically this study by Lindor in 2004, unfortunately, what it does is that they compare URSO versus placebo, and after 2 years, basically, they find out that the patient in placebo did as well as the URSO. That's why URSO, unfortunately, has come out of not being a good potential treatment for NASH. There has been also use of the statins. We can see here where it was an open-label study back in 2003, 6 months duration. There was improvement in the liver function test, and there was improvement in the histology. The problem with the statins studies is that patients, even though they are treated with the statins and the liver enzymes improve and there's some histological improvement, unfortunately, there was weight gain in pretty much all patients, averaging about 10 pounds. And that, unfortunately, then basically what happened is the fat shifts from the liver or visceral fat shifts to other areas of the body. And we also have some other studies done, and that basically have shown some improvement in the liver side, but unfortunately they are not as good as losing weight. Then to summarize the presentation, basically the advice I will give to all of you that are taking care of pediatric children, or their pediatricians or family medicine or primary care providers, mid-levels, all of us that take care of children, we got to look at the BMI chart. We need to calculate the BMI in every single patient that we see in our clinic that are over 2 years old. We always do weight for height or length, but I think for sure in any kid over 2, we should be calculating BMI. And I think most of our practices are doing that nowadays. The prevalence of obesity in school-age children is high. We need to understand that, epidemic proportion. Therefore, we really need to screen these kids not only for lipid profile, hypertension, or having glucose or hemoglobin A1C and so forth. We need to check them out for ALT at least as a screening test. For if it's elevated, then later on come back and try to analyze, how high it is or how the rest of the liver function test and so forth. But we need to screen these kids for increased ALT because the obesity-associated steatohepatitis is very common in kids that are their BMI is over 95th percentile, even over the 85th percentile. We have overweight kids. We already have a risk less than 95th percentile, and still the risk is 5%. Then we need to understand that and make sure the ALT in those kids. The kids with liver disease in relation to obesity or overweight, they are going to have a tendency for fibrosis, and that's something that is extremely important because it seems like kids, the young liver in front of an injury have the tendency of having fibrosis as a response to this injury. Unfortunately, this is going to progress then to cirrhosis. There's the concern here is that this fibrosis will progress and eventually may predispose to end-stage liver disease and even hepatocarcinoma by adulthood. We have kids that has been transplanted by 18 or 19 years of age because they have come with decompensated liver disease or cirrhosis. This is something that is unfortunately progressive and very important to address. Therefore, I will suggest if you have a 2 or 3-year-old with a BMI more than 85th percentile, there's a 20 and 25% chance that this kid will be obese by age 25. Then this should be addressed with the parents. We need to start talking about, feeding habits, what they're doing, that things that we could address. For example, are these guys getting too much juices, refined sugar, try to address those issues around that age. But if we have a 3 or 6-year-old with a BMI over 95th percentile, then we know the likelihood of being obese by 25 is going to be 52%. And we understand that these kids may have also comorbidity at this given time. These patients should go to a weight control program as much as possible. I understand the limitation. We cannot send all the patients to a weight control program, but when this is available, we should do that. But we need to start addressing the issue of weight control, weight loss, and also increase of physical activity. In these patients, we need to look at the liver function test along with the other pertinent labs that we all know about, the lipid panel, hemoglobin A1C, fasting glucose, and insulin to do the ratios that we do to assess for insulin resistance. Then keeping on with the kid that is older than 6-year-old with a BMI over 85th percentile. Notice that here is over the 85th percentile. Now we're talking about almost 83%, 55 to 83% chance of being overweight or obese, at 25 years. This patient, again, needs to be referred to weight control. These kids really needs to get a screen because then now they can have significant comorbidity, and we know that has been well established. And these kids, as I say, can develop early cardiovascular disease, early myocardial infarction because of hypertension issue, because of hypercholesterolemia, because of diabetes that can be an issue at that time. Along with all these things, liver disease also is important to be assessed because this is a progressive disease. This is something that can lead the kid to major problems with morbidity and mortality. The approach of this problem is like we all are doing, including the state of Nebraska. We got to have a multidisciplinary approach to this because it's not only gastroenterologists, pediatric hepatologists as myself, or endocrinologists, or cardiologists, and so forth, pediatricians. Everybody needs to be involved. And we understand that this is a very frustrating problem because most of the time we cannot take care of these patients the way we would like to take care of them. Then this is something that everybody needs to be involved. When we say multidisciplinary, it's not only us in the medical field, it's also talking about the people that is responsible for the planification of the cities, have parks available, has community centers available. I mean, everybody needs to be involved. This is a long-term issue, but if we don't start tackling, we are going to have major problems as a society in the near future. But we all, again, needs to be involved. Even the family needs to be involved, obviously. That's a very important thing. As we say, this is a three-leg stool where we have the family, we have the child, and we have the medical community, or all the people, older people that can help. But each one, even the child and the family, needs to be involved. And even though everybody agrees on how frustrating treating obesity can be, frustration shouldn't be reached before a fair attempt has been made in each case. We cannot just say that this kid is not going to lose weight because this is what I have done so many times. If we can get just one kid interested in really engaged with losing weight, I think we can do a major impact. We can have major impact in overall outcome. I have kids that has almost cirrhosis, and when they were about 12 or 13 years old, and they really got engaged in the things that they needed to do, eating healthy and losing weight. And by 18 or 19 years of life, they have an absolutely normal liver because they lost their weight. And I think this is what we need to focus on, that there is hope for these kids. And this picture that Felicia Webb took, and I'm there in the middle looking, taking care of one patient and looking to the other side. And I asked her what she want to say through this picture. Basically is that this problem won't go away just by looking the other side. It's going to be there. We need to take care of it. I just want to thank you very much for your attention, and I open for questions.
Thank you, Dr. Quiroz. We'll now open the webinar up to any questions anyone might have. Again, you can type questions in under the chat or questions portion at the right of your screen, or you can press the little hand. You can raise your hand, and we will unmute your line so you can talk to Dr. Quiroz about your question. We'll just wait a few minutes to let everybody get their questions in.
Dr. Quiroz, this is Holly Dingman, and I have a question about if you could talk about the role of diet and the antioxidant therapy for treatment. Is there a role for diet?
Yes, definitely there's a role for diet. I think that's why I think the dietitians or the nutritionists play a major role, because there are ways to increase your the antioxidants in the diet through increases, certain products. We go after products that have vitamin C, vitamin E, vitamin A. We know carrots. We know, just to mention some, or orange, or things like that will promote a better antioxidant status. And I think part of the problem is that these kids with obesity, they don't eat well, and that's why the antioxidant status probably is different, because they don't have a healthy diet that will include those antioxidants. Also, obviously there are, we talk about the fish oil nowadays, and food that can have omega-3 and things like that also are going to be important I think to prevent this increase of oxidative stress. But I think, yes, diet is extremely important. I think the entire management of this problem is extremely important and crucial, and that's why we need to work together to try to promote that.
Thanks.
Do we have any other questions out there? Just to kind of go over what you've heard today, the continuing education credits, you will actually receive an email in about an hour, I guess, with the link that you can go to. It'll take you to Creighton's website, but there's a specific link that will be emailed out to you, and then you can take the evaluation and post-test for your CME credits. Please visit the Childhood Obesity Prevention Project website at the www.nedmed.org /COPP.ASPX, and there you'll find the first webinar in this series is listed as an encore there, as well as the actual Childhood Obesity Prevention Project training video, and all of the resources that are available with the Childhood Obesity Prevention Project and the Foster Healthy Weight and Use model. Here's that slide again to show you where you can get those materials. You can email Holly as well. And we'd like to thank everyone for attending today. And if you have any questions about the Child Obesity Prevention Project or anything you heard today, please feel free to email us. And I want to thank Dr. Quiroz so much for taking the time to share such an important topic with us today.
Thank you.
Thank you all.